muscle, but not so much sensory fiber. You can break the cruciate ligament, you feel a pop, you don't feel pain. If it doesn't swell up, because it's bleeding. When it swell up, it's bleeding, stress the capsule, and then you start to have the pain. So when you assess a patient, I said you have always think about how innervated is that tissue, because the innervation is related to the painful afferents. So if you cut your nails, you don't feel any pain. If you go just a little bit lower, you feel a lot of pain, because the innervation of the nails and of the fingertips is completely different. So even the tissue, you have to understand which tissue is innervated and what kind of innervation it has, because it can be more painful tissue, painful generator, or not, in relation to innervation. And this is critical, it's very important, because you will see that the tendon, the paratendon, the fascia around the tendon sheath is well innervated. It can generate pain, but the tendon by itself is not. So we have published quite a lot in that. We explain it, and now worldwide are all agree that you should talk about tendinopathy. You should talk about rather than tendinitis, because a lot of time the inflammation is not in the tendon, but is in the sheath around. And that is the what during the painful sensation that the patient refer. The sheath around. We have a lecture about that today. We don't have time, but that's the idea that they have to take home. Sometimes we have muscle fiber in the neck. We will see in the scrotum, in the sternal sphincter. But remember that all the animals have the panniculus carnosus, so like a platysma all over the body. Okay. So remember that each of us could have muscle fiber, and it can be a lot of anatomical variation. So one have a platysma that go until here. They smile, you feel a ring until here. Okay, for instance. Resistancy. Look, 8 kilograms. We're talking about 20 and more pound resistance. And it is more resistant at the top of the chest rather than the lower part. Because right here, this is trapezius, is full of vessels. And so that means that because there's a lot of vessels, the superficial fascia right here is even more resistant than the epimysial fascia, the deep fascia over the trapezius. So this is very resistant. It can get resistant up to 10 kilograms, like 30 pounds, even more, okay? So it's really resistant. And as you go down to the low back area, the resistance is in one direction, the other kind of drop, okay? What about vessels? Saphenous vein, Achilles tendon, medial malleolum. The vein, you see it right here, come up the vein, and then we have all the vein right here. The vein is inside a bilamination of the superficial fascia. So when you are talking about problem of the superficial vein system, superficial fascia has to be taken into consideration. Even because, look, this is the gracilis, adductor minor, femoral artery, femoral vein. The neurovascular sheath, so the fascia that surround the shoe structure right here. So I want to say that this vein is quite in trouble to bring the blood back. Because does the superficial fascia have a, muscle pump possibility to be squeezed, to be, how this vein, poor vein, can bring the blood back? It's not for sure squeezed as a femoral vein. It doesn't perceive like the pulse of the artery right here. It has the valve, it's true, but how the blood go back? Anybody has suggestion?
Muscle contractor.
Yeah, but it's an indirect muscle contractor, thanks to the superficial fascia. So we know the superficial fascia go all around, even in front of the tibia we have superficial fascia. So you have superficial fascia all around, a bilamination with the vein inside. So when you increase the diameter of the cuff, this bilamination will collapse. When you decrease the diameter of the cuff, the bilamination will increase. So it's an indirect muscle pump that works only because you have a superficial fascia all around. Otherwise, what happens if you have the vein right here? I just push on side, that's it. I don't squeeze the vein. You have to squeeze the vein to let the valve work properly and bring the blood up. Okay? So for instance, this is a video. This is the saphenous minor. So you see the bilamination. You see the vein is always in the middle of the bilamination. If you pull right here, right there, the vein will squeeze. Okay? So whenever you increase the diameter of the cuff, pull right there, this one will squeeze. I move the transducer from the Achilles tendon up to the popliteal cavity. So you see that gastrocnemius, soleus, I'm getting close to the popliteal cavity, and now the vein go down to the popliteal cavity basically, and all over is traveling in the cuff is always inside a bilamination. The gastrocnemius, the soleus, and the septa pull down as well. So this is to explain that the fascial system is very important. The tension, the quality, also for the possible generation of varicose vein. I believe that you are not surprised that people with the problem in the leg, why not? That leg then it get also varicose vein, and then the leg get also lymphedema, because you start to, when your fascial system become rigid, you block the vein, you block the lymphatic system. So you start with lymphatic problem for years, for like with sciatic pain for years, and then varicose vein, lymphedema, you know, the patient gets worse and worse over there. Why? Because everything becomes rigid, it collapses everything. So just to conclude a little bit about the superficial fascia, remember, like even the capillary have to go through the superficial fascia. If you have a rigid superficial fascia, it can collapse. You have the plexus, thermoregulation is managed by the superficial fascia because are there the capillary. So if you have a stiff superficial fascia, you can have like a white skin over there. Lymphatic drainage, it travels in between the superficial fascia and skin septa. So lymphatic, edema, lymphedema is extremely related to alteration of the superficial fascia. And nerves, because everybody should know that all the nerves that we have, all the sensory nerves that we have, 100%, they have to go through a hole in order to reach the skin. So 100% of our nerve can be entrapped in this hole with this deep fascia. Okay, this is well described in literature, but a lot of time people forget. Okay, so I will always say that you can never exclude that your patient have a nerve entrapment. Okay, because all the nerve have to go through a hole. But then the nerve gets superficial and travel for a while in the superficial fascia before to reach the skin. So even if the superficial fascia is alterated, these nerves can be stressed and they can generate allodynia, hyperalgesia, dysesthesia. Here, you drop just the possibility to transmit, so you can generate numbness, pins needle, all this kind of problem. But again, all the nerves, if they go in superficial, they have to go through a hole. But don't forget that the nerve have to go also through the intermuscular septa. In the intermuscular septa have also motor component. So you will have patient a foot drop due to peripheral nerve entrapment. I say from 2 to 3 surgeon, because after knee replacement, the patient will lead in the bed for an hour, scar, nerve entrapment, foot drop. Okay? And the surgeon was quite scary, okay, about that. And then it was just a peripheral entrapment. It will resolve, okay? But be aware, it will happen a lot, okay? And it's not a lesion of the nerve, it can be, but it's just an entrapment. But if you don't treat the patient will add a month with that problem, okay? So, take our message for superficial fascia. Mobility of the skin. Toes, ringo, plastic surgery, think about like lifting. How many patients come and say, look, since then I feel I'm not able to breathe. I feel that all my face is in an incorrect place. I feel that I'm in tension. I feel like a sort of heaviness in the face. Okay, because they make like some adhesion between superficial deep fascia. Okay, I have a lot of them in the last period. Protection of vessels like varicose vein, tunnel filler, weakness, superficial fascia is involved. Lymphatic drainage, painful cellulitis will be like a key situation to treat. And of course, separation between exteroception and proprioception. Okay, so it means that normally if you push, you will activate the receptor right below the skin. So I feel something from outside is touching me. But if you have an increase of the stiffness of superficial fascia, retinacular cutis, the same pushing will transmit load down and you will irritate all the receptor. So you have a bombardment from there that will generate like a kind of painful sensation. Typically when you have like a contusion in the knee, in the elbow, close to the joint, where you don't have so much fat. Because less fat you have, easier you have like an adhesion between skin and underlying layer. So like allodynia, I hit my knee, and since then I cannot even touch my patella, it's burning. You treat the burning sensation, allodynia will go away. Because it's just a lack of gliding between deep fascia and superficial fascia. It happens quite a lot. So this is our scarpa fascia, we will see later on. Superficial retinacular cutis, thicker. On each of them you have a skin set, a capillary that go through, and we reach the skin. Right here you have a big vessel that go oblique, come here, and split in small capillary that will go up through each of them. These are the deep retinacular cutis or deep skin septa that are not in a correct disposition. What is wrong right here? These are vertical, you see? They're vertical because probably this guy died for a heart attack, so he have like on a side like a swelling all over the body. So you have fluid also right here. So this skin septa should be oblique like that. And all this part right here should be much closer. But because you have a lymphedema all over the body, you generate a virtual space at this level. Okay? All right, so let's go a little bit with the deep, and then we want to move on the other room. So what we're going to talk about today, deep fascia, aponeurotic or epimysial. The aponeurotic is the deep fascia of the limbs, fascia lata, crural fascia, antebrachial fascia, brachial fascia, thoracolumbar fascia, and rectoabdominal sheath. These are the three parts: thicker, rigid, heavy, low transmitter. The epimysial can be the epimysia of the limbs. You see each muscle is small epimysial fascia, or the deep fascia of the trunk, because each muscle right here have a fascia above that is strongly adherent to the muscle. So let me show you. Remove the fat superficial fascia. Remove the superficial fascia, deep fascia. Okay. Same name, different tissue. This is very elastic. This is white, rigid. This is tensor fascia lata. You see the muscle within the fascia lata. I open up the fascia lata. I see the quadriceps with the epimysium. Epimysium is like a point, like a 100 micron. Okay. This is like a 1.8 millimeter, 1.4 millimeter. They say, look, 1.4 millimeter is nothing. But do you know what is the thickness? I mean, it has to be millimeter, but thickness of the transversus muscle of the abdominal wall. How thick do you think it is? If you're talking inch, you don't have to say millimeter. I mean, in a young person, 24 years old, the thickness of the transversus is between 3 and 4.5 millimeter. Okay? That is muscle fiber. This is connective tissue. So 1.4, 1.3, this one carry tremendous amount of load in comparison to muscle fiber. So you will see that this piece right here of connective tissue, nobody in the room will be able to break if I ask you to pull, because it's very rigid. This direction will be impossible. In this direction, it will be hard, but you will be able to. Let's do it then. This is the Achilles tendon, superficial fascia, take it off. And we have our beautiful deep fascia. You see collagen fiber in one direction, another direction, another direction. There is a hole in the popliteal cavity. For what? For the saphenous minor to come up and get in there. Okay? So you can imagine the adaptability of this hole is critical. So we published first that the deep fascia is not an irregular mesh like that, like it was described in literature for century, but it's a multiple layer. What is the difference? Multiple layer can do this. Irregular mesh is lack. Okay? So we have multiple layer, you can adjust, you can glide, you can adjust, the whole change the shape, but it's always there. If you have an irregular mesh, you get stuck.
It's the same class.
So, I know. I'm late, damn it. So remember that the deep fascia, I mean, this ability is fundamental, because if it doesn't, you will see the layer will glide because you have loose connective tissue in between. If you don't glide, you start to have a chronic stress compartment syndrome. You will see a lot of athletes that they get fasciotomy for this reason. If you want, you can take it off the deep fascia, and you will see below, okay, that distally it will be easier, but proximally it will be very hard because there is a lot of connection between fascia and muscle. And we will see this. We call myofascial expansion. Muscle fiber that instead to originate from the tendon, they originate from the inner surface of the crural fascia. Or muscle fiber instead to go to the tendon, they go into the fascia. And this will be like the topic of the day. We'll see a lot of that myofascial expansion, okay? In the same the limbs, right here, okay? You take off superficial fascia, deep fascia, you see this is an reinforcement. There is reinforcement is telling you that down there's a lot of low transmission. So that means that if I open up right here, we will do, you will see that the muscle below will come up because they are attached to the inner surface of the fascia, okay? And remember that each of you have a different shape of the fascia. If you check like a professional picture, you will have a different reinforcement because the reinforcement, they grow up with you in relation to what you are doing to facilitate your motion. At the opposite right here, look, what is this stuff right here? The retinacula. But the retinaculum will go from here to here, from there to there. What is exactly the border? You don't really see the border. Because the retinaculum is a thicker area of the fascia, deep fascia. So it's not separable. And of course, we say this area is extremely innervated. It's very critical for the coordination of critical joint. This joint, the ankle. Why you have a two, even more retinaculum right here? Because you are an ankle that have 3 degrees of freedom with calcaneus, fibula, you know, tibia. Here we have like a ulnar radio, 2 line of bone. So it's really critical the coordination to avoid subluxation. So when you need a lot of coordination, you need a lot of fascia with a lot of receptor. So fascia is the organ for proprioception. When you need proprioception, perception of your body, you need a perfect body system, fascia system in this case. Look, this is the biceps. It has its own epimysial fascia. This is the brachial fascia. It seems separate, but in reality, even the biceps have a major connection with the fascia. Do you know which one? The most famous, Google know that. You can check, Google will tell you the answer. Is the lacerdus fibrosus. Try to hook your elbow right here. Try to pull up this cord right here. What come up? The biceps aponeurosis. You see how big is this expansion? This is the way how biceps transmit the force in the brachial fascia. If you check a bodybuilder that they have done like steroid, a lot of them, like some of them, they have a tear of the bicep aponeurosis because steroid pump up the muscle and not the tendon. So they tear the bicep aponeurosis and they have to have surgery, otherwise they don't lift anything. At the opposite, you tear the long tendon of the biceps, do you have any major problem? They must become shorter, but do you have any limitation in your life? Not at all. So you cut a tendon, perfect quality of life. You cut the myofascial expansion, you need surgery. Okay? So just to give you an idea how important are this infrastructure. Okay? So it has to be taken into consideration. I mean, collagen fiber, this is one layer. So longitudinal section of the fascia. The same layer right here, but then we have a loose connective tissue, and then another layer come out from the screen. And then we will have a loose connective tissue and another layer. Because normally deep fascia have 3 layers, 1, 2, and 3, with an interface of loose connective tissue that allow the gliding of the different layer. Okay? So dense, loose, dense, loose, dense. This is how it works. And then you can have the skin receptor right here, or you can have a loose connective tissue and the epimysial fascia of the muscle. Basically, you have a really few elastin fiber that may make the deep fascia a flat tendon that is able to transmit a lot of force because it's not adaptable. Okay, you cannot stretch. Whatever you pull here, you transmit distally. It's a perfect flat tendon for your body. So this is like a 3D reconstruction. You see like a first layer, second layer, third layer, or a portion of the first, or the second and third one. So this allows you really to glide properly. But don't forget that between one layer and the other, the blue one substance is loose connective tissue that allows the gliding. So that is why for centuries we thought that we have a irregular mesh, but now we know that we have a multiple layer, one layer over the other. So we have brachial fascia right here, biceps aponeurosis, antebrachial fascia. If you take a sample right here, you will have the red layer, loose connective tissue, yellow layer. Right here it went out, but there is more loose connective tissue. Another layer, loose connective tissue, epimysium, and then muscle. This is how is your fascia system. Whenever you bend your elbow, what happens? This angle will change, so this will glide from this, and also the muscle will contract in another direction. So your body, everything moving your body, everything has to be independent. Because when you move something, it doesn't have to stretch the nerve, that has to squeeze the vein, okay? So you need an interface made of loose connective tissue that allows the gliding. Again, don't forget that the viscosity of the loose connective tissue is critical. If this one becomes more viscous, like a glue, your elbow will become rigid. And rigid elbow, it means irritation of nerves, pain. It means overstress of the joint. In a decade, arthritis. okay? So this is like the beginning, the first momento of a disorder. Increase of viscosity of loose connective tissue. It is like where we are focused, and we publish an article about this, and we find out that in chronic epicondylitis, the viscosity of this is way higher than normal, okay? And we publish a couple articles of that. Like this is a fresh sample, is a pork chop, all right? So look, tibia, fibula, you see, if it's fresh, everything glide. I move in everything glide. You see this compartment glide over the soleus, over the gastrocnemius. Each single structure is gliding. Why is that? Because you need independence. Each muscle has to be able to contract independently. The nerve has to be isolated. So between each structure you have an interface made by 2 layers of fascia and loose connective tissue in the middle. The intermuscular septa is what is? Instead to be 3 layers, 1, 2, 3, 4, 5, 6, 7 layers. Okay? So it's like a tube that helps to transmit force proximal to distal and to separate what is in the middle from what is outside. So it's a beautiful, amazing infrastructure that we have. These are real fascia that we are going to see in formal date, so exactly what we are going to see right now. So right here there's the knee, tensor fascia lata, gluteus max. You see collagen fiber in this direction, collagen fiber in this direction, collagen fiber in this direction. You see with your eyes, you will see with your eyes this collagen fiber. Each collagen fiber have a meaning. So we are far away to understand our fascial system. It's a milestone project. So only that when we will know from where this collagen fiber comes and from where this collagen fiber goes, we will know our biomechanics. But this area is quite simple. So like this collagen fiber, from where they are coming from? The tensor fascia lata right here. So these are the flat tendon of the tensor fascia lata. Where this collagen fiber coming from? Question for you. From the gluteus max. This is the flat tendon of the gluteus max. And then this one will come from vastus medialis, vastus lateralis, short half of the biceps, gluteus medium. Okay, it's a little bit more complicated. Look, this is a small nerve coming from a hole. If the gliding between the layer right here is altered, what happens is hole can be squeezed. And then the woman, like the 60-year-old woman at the sleep on side, they say, look, you know what? I have a burning pain right here in my hip. They told me that I have a bursitis. It's not. They told me that I have arthritis. It's not. Okay? They told me that it's in my mind the problem. I don't know what to think about. In reality, is what? It's just the rigidity of the fascia. You treat it, and the burning sensation go away. You know, trochanteritis, you know, all these kind of diagnoses. It's just an entrapment of the nerve due to the fascial rigidity. Okay? So look, if I try, I can separate the 3 layers without using the scalpel. But I can do until, let's say, great trochanter area. Because after that, the 3 layers start to fuse. Why is that? What you really need right here, what you really need at the knee level. You see right here, everything becomes tighter, rigid, and white. Because the 3 layers, they fuse and they generate the portion of the collateral lateral ligament. So here's fuse the layer, here's separate the layers. Why is that? What do you need right here? What do you need right there? Right here, what you need? Stability. Because you don't want to do abduction, adduction of the knee, isn't it? What you need right here? Mobility. Because you have 3 degrees of freedom. So worldwide, people are still fight because the people said that fascia work for mobility. Now fascia work for stability. In reality, fascia work for both. Depending if the 3 layers are free to glide or if the 3 layers fuse. Okay, it's only about anatomy. Okay, So for this reason, if you know the anatomy, you don't fight. You know why it's there and what is the reason for. Okay.